have my own independent practice, and I'm a faculty at Hunter College teaching at the graduate program. I have experience of 20 years in MS. I've done inpatient initially before the 20 years, then joined the Corinne Goldsmith Dickinson Center for Multiple Sclerosis at Mount Sinai Hospital, and left to do teaching and do my own independent work in the end of 2019 before COVID happened. Who knew what will happen next? Anyhow, I'm happy to provide you an overview about MS. The outline of this program will include definition, epidemiology, etiology, and pathophysiology. Then we'll discuss the diagnosis and workup, phenotype, prognosis, and we'll finalize with a case study. I would like to say that I'm going to have 2 more programs that will be on our website later on during the year about MRIs and about treatment medication. So this talk is not focusing so much on biomarker, MRIs and others, and medication. It's not focused on those. So let's begin. So before I actually begin with definition, the objectives of this program is to first to understand the epidemiology, etiology, and pathophysiology of MS, which are important in our clinical practice, explore the clinical diagnosis of MS and supportive workup briefly, state the phenotypes of MS, including the prodrome phase of MS, and apply the prognostic factors indicator into the case studies and our clinical practice. So what is MS? What is multiple sclerosis? MS is an inflammatory, demyelinating, and neurodegenerative disease that occurring in the central nervous system. It's a chronic illness that's caused by myelin reactive T cells in the periphery, and that become activated by an environmental triggers, potentially a virus or a bacteria that then eventually invade the CNS, the central nervous system, and cause destruction of myelin and axons directly and by releasing various inflammatory mediators that we'll talk later in the pathophysiology section. So we know today that MS happen in individuals that are genetically susceptible to the disease, with a combination of immune dysregulation and environmental factors. In addition, the name comes from the word scarring, so that's sclerosis, and multiple site in the central nervous system. Simply, it attacks the myelin and the axon itself, leading to symptoms such as numbness, weakness, which we again will discuss later. They can be mild or severe, loss of vision. Often symptoms more often are mild than severe. The disease progresses over time, and the disease itself is unpredictable and definitely vary from one person to another. MS is considered a silent illness. There's some clinical visible entity symptoms, disability over time, relapses, patient outcome, but there are also some subclinical evidence of the disease, such as brain atrophy, lesion burden, and neurofilament level, which we'll discuss again briefly later. It will be more details in my next talk. This is a courtesy of Giovanni, a nice illustration showing almost like an iceberg, what's above the surface and what's underneath. So it looks quiescent and it looks silent, but it's not quiescent illness. And really what showed that it's not a silent illness and quiescent, the topographical model of MS of one of my colleagues, Dr. Stephen Krieger, who is a faculty at Mount Sinai Medical Center in New York City. So as you can see, you have 2 diagrams here, and the first diagram talks about the clinical presentation of MS, and the diagram to the right of this, the B diagram, include also the subclinical, not only the obvious. So in A, you can see that those relapses and disability that appear, those white almost peaks and mountains, are shown because these are the clinical symptomatology and evidence of the disease itself. And B shows, and you can see on the bottom here, reflect the functional capacity of individual, and then C, it's the water levels that reflects the loss of functional reserves. It's all about reserve, how much we have, and this usually estimated by brain volume metrics. The D and E on the right include those subthreshold topographical peaks, which they show and demonstrate the T2 lesion of burden of disease, numbers and volumes. And lastly, the black dot on the E, you can see right here, show a black hole, which reflect axonal loss. So you can see that there are always some activity, some lesion burden below the threshold, and you can see it either in the spinal cord, that's this section, or in the brainstem and cerebellum, the middle section, or in the cerebral hemispheres. And the next slide, Dr. Krieger shows what happened in one specific patient. So this really show the disease progression again in one hypothetical patients. The bar rising above the dotted line. This is the dotted lines. Rising up from the bottom of the shaded area represent lesions in the central nervous system, while the dotted line across the top of the shaded areas are the threshold at which symptoms appear, which is known as the clinical threshold. So you can see right here where you have right below the symptoms appears. So you can see differences between patient early in the disease, between 0 to 5 years, 6 to 10, and then the lastly 11 to 20. So you can see there are much more bars rising up from the bottom as disease last longer in the section of 11 to 20 years. The clinical thresholds defines whether a patient develops signs and symptoms or whether their lesion remains subclinicals. And lesion appearing below the dotted line do not usually cause symptoms, while those above the threshold do cause symptoms. Dr. Krieger's model hypothesized that MS, as I mentioned earlier, it's not always entirely quiescent during remission or during the time that you do not have relapses, of course, or any progression of disease. Rather, the brain's ability to compensate for the effect of prior accumulations of lesions declines, denoting disease progression. So again, reserves definitely go down throughout the year. So MS is not a silent illness based on the diagram that I showed from Giovanni and also the topographical model by Dr. Stephen Krieger. So let's talk about epidemiology. Some general markers of the disease. It affects approximately 900,000 people in the United States, and worldwide about 3 million. It's one of the leading cause of non-traumatic neurological disability in young adults and teenagers, children as well. Mean age of onset is 20 to 30 years, female to male ratio 3 to 1, and some speculate 4 to 1, and it can lead to physical disability, cognitive impairment, emotional issues, and reduce quality of life. Some factors related to ethnicity. We know today that there is a rise in the incidence of MS in underserved populations. So I have few facts from the citation that you have below, Langer, Gould, and Wallin. The MS incident among whites is 7.28 to 9.32 per 100,000 person years. It's very similar, although a little higher in Blacks, 10.2 to 12.13, and then lower in Hispanics and Asians. We know today that the disease is much worse in underserved populations. You can see worse prognosis in minorities, more aggressive disease. More often they experience optic neuritis or myelitis, have increased brain atrophy, and increased disability that was seen mostly in Black, although in all minorities, but mostly in Blacks, poor recoveries, and shorter time to subsequent MS attacks compared with white patients. Looking at the mortality rate of all populations that are diagnosed with multiple sclerosis, so among white, an age-adjusted mortality rate was 0.9 and 1.5 per 100,000 male and female patients, respectively. In Black, you can see it's pretty similar to white, 0.75 and 1.42. In Hispanic, it's much lower, 0.23 to 0.35, and then lower in Asians. So approximately MS reduces life expectancy by about 7 to 14 years. What is the etiology of MS? So we still don't know in 2022 what is the main cause of MS, although we think it's a complex disease and there is an interplay between a few factors. Number one, genetic. There is a genetic predisposition to have the disease. We can see increase in incidence among twins, and the most prominent genes that is prevalent in many patients with MS is the HLA-DR2 that is involved in immune regulations. Environmental factors that may trigger the disease in combination with genetic predispositions include viruses. We keep talking about Epstein-Barr virus. Just recently, there was an article about this. Other environmental factors include obesity, vitamin D deficiency, and autoantibodies and antigens that I'll discuss in a few minutes. Immune dysregulation, there is high activity of Th1 cell, Th17s, less of regulatory T cell functions, and higher B cells function that lead to the disease. And today, we also talk about the microbiome and the immune relations between the microbiome and the CNS, the central nervous system, and MS, and how it impacts the outcomes of MS. Epigenetic factors include DNA methylation, histone modifications, microRNA, and others. So definitely a very highly complex disease that involves multiple factors and not one gene or one environmental factors. Still, although I talked about the incidence in MS, still mostly Caucasian and whites are mostly affected. Children increased incidence are in minority underserved groups. The more distant you are from the equator, you have higher risk to have MS. So we talked today a lot about vitamin D deficiency. I'm not quite sure where it fits, but it is related to somewhat to the disease itself. Smoking was associated with progressive MS. High sodium intakes also has been associated with MS, and obesity shown to be a risk factor to develop MS in adulthood. So childhood obesity is a risk. And insufficient exposure to mild infection in early life may also contribute to the trigger of MS because of less immune exposure to other infections, and less immune maturity, perhaps. I mentioned the autoantigen and antigens. So there are a few antigens that are considered in the evolution of MS and the diagnosis of MS, or in the predisposition of MS. A few of them are the ones that are present in healthy control. However, they are much more active, highly active in patients with MS. Myelin basic protein, myelin oligodendrocyte glycoprotein, MOG, which is responsible for the integrity of myelin, myelin-associated glycoprotein, MOG, which also is responsible for remyelinations and other function, and the NOGO receptor, myelin maturation and axonal growth. The antigens that were discussed in the past and in recent times that are involved potentially in MS are Epstein-Barr virus, chlamydia, chlamydia, pneumonia, human herpes virus 6, herpes simplex virus, and dietary agents such as milk and others. So let's move on from the etiology that we have some knowledge to pathophysiology. Many studies have been done in recent years to think about and understand better the pathophysiology of MS. So the first, this is a bit crowded slide, but I wanted to talk about the multifocal inflammations and demyelination that occur in MS, thinking about the increased permeability of the blood-brain barrier, the BBB, breakdown of all these meningeal layers and the choroid plexus, leading to that inflammations and demyelinations and axonal loss. You have some glia loss and some higher activity of glia cells. So for example, oligodendrocyte loss. So then you end up with having less remyelination. The astrocytes have a dual role in MS. So on one side, they promote release of anti-inflammatory cytokine, such as the transforming growth factor beta and IL-10, which lead to reduction in inflammation. However, on the other side, astrocytes also release chemokines that retain autoreactive Th1 cells, which are pro-inflammatory, and they lead to demyelination and axonal loss. So from all these processes, and mainly the invasion of the central nervous system with hyperactive T cells and B cells, there is gliosis, axonal degeneration, demyelination, and then leading to neuronal death and scarring. There is the axonal loss that we see on certain MRI, which I'll share soon. The axonal loss is a major cause for neurological disability. And the biomarker that can help you here, as here, either systemically in the blood or in the CSF fluids, are neurofilament, either light or heavy change, and amyloid precursor protein. This slide is a courtesy of Dr. Bruce Trapp, and you can see the MRI on one side and then a biopsy, let me go back, almost showing. So if I look at the left, it's a T1 hypointense black hole, which we call black hole, which all these hypointense lesions show a T1 hypointense lesion, show the axonal loss. And you can see the bulb, the change of the axon, the green bulb that you can see on the left of the side under A diagrams show the destruction of the axon that leads to functional disability. The B show the demyelination, and you can see areas right here that have a green, that's the axon. So all the myelin that's covering, the layer that's covering the axon, you cannot really see that. And that corresponds mostly with T2 flare sequences that you can see on the right on the MRI, multiple lesions around, it's more up in the cortex, but around the ventricle if you go down. And I have another photo that you could show that. But it shows the demyelination in one side and the axonal loss that occur in MS. So what we know today that there is an cytokine imbalance in MS. You have more Th1, it's heavier. You can see here more inflammatory components, cytokines and chemokines such as interferon gamma, IL-2, IL-12, tumor necrosis factors, and you will have less Th2 anti-inflammatory component, IL-4, IL-2, IL-10, sorry, and TGF-beta. So you can see that the equilibrium in normal control is pretty even. You don't have heavier chain as compared to those with MS. And then lastly, I will talk about the microbiome briefly. Normally in people, there is an equilibrium between those inflammatory species or microbes as compared to anti-inflammatory, and many of them are complicated names that it's hard to even remember and pronounce. And when you look at MS, definitely there is evidence that patients with multiple sclerosis have distinct microbiomes that's differ than from healthy individuals. So you can see the balance is off. Those inflammatory firmicutes are much more heavier, much more in numbers and volume as compared to bacteria that's which have anti-inflammatory effect. I think we are learning more about the microbiome and trying to understand how the gut is involved in a multiple sclerosis. This is a diagram that shows disease progression in MS. This is courtesy of Dr. Giovanni. And you can see that the diagram on the right talks about the CNS inflammation. The first compartment talk about the brain atrophy that patients with MS lose over the year. And earlier in the disease, you lose brain atrophy much more triple than those healthy control. And then thinking about the neurological reserve that I mentioned to you, the more neurological reserve we have, we can compensate better and can maintain our functional abilities over time. Although once you go over that threshold, you lose functions. See, you talk about the MS lesions, that some new lesions that appear, gadolinium enhancing lesions that appear that lead to relapses, new onset of relapses, or progression of disease, depending on the phenotypes of MS. And then once you have lesion, once you have increased activity, you'll have clinical symptoms, and that's under V. And you can see illustration of the EDSS done really nicely and how you progress over the year with encountering more symptoms of MS, such as fatigue, numbness, and many others. Lastly, E, talk about these, the diagnosis and treatment, and more so emphasizing the clinical symptoms that you have over time. Start with IRS with no clinical symptoms, and then CIS, the first episodes, and then relapsing form that lead to those clinical symptoms, and treatment. I'm missing actually, the E was supposed to be D on the slides. Sorry about that. So D should be clinical symptoms, and then E should be the diagnosis and treatment, which I'm not focusing though in this talk. And that's the reason that I omitted it from there. So MS diagnosis. It's important to diagnose and not misdiagnose the disease. Still today, misdiagnosis of MS occur about 20% of the times that we actually do. So 20% is pretty high numbers to think about misdiagnosis. So importantly, MS is a clinical diagnosis. Although we have some biomarkers and tools to identify and diagnose MS, it's a clinical diagnosis. So the story and the neurological exam, which will be included in the workup, are the most important factors that are involved in MS. We'll talk about MRI, dissemination in space and time, but important to think about MS as a clinical diagnosis. And usually, if you don't have any alternate neurological disease to explain the signs and symptoms, you probably say it's likely MS. Since we don't have a blood test or any specific test to identify and say this is MS, it's more of a combination of factors that we as clinicians think about and put it together. It's almost like a puzzle that you put every piece together and then you come with the diagnosis. So prodrome. So what is an MS prodrome? So the prodrome is the early signs and symptoms that many of our colleagues talk about today. I'm sorry, I don't have the citation here. Hopefully I'll have the citation later on and I can provide it later on by, these studies were done by Tremlett and our colleagues, explaining the prodrome and talking about those early signs or symptoms indicating the onset of the disease or illness. So those symptoms can be fatigue, pain, headaches, depression, anxiety, bladder issues, infection. They can come sporadically during the year. It could be 5 years of symptoms that we didn't diagnose the patient with MS since it was sporadically around, but it's a prodrome. It's just early warning signs almost, if you think about, or early signs that can tell us that the disease will appear at one point in the future. So it can be, as I mentioned, months or years before the MS onset, before the typical MS relapse that we are familiar with. And so she has a really nice, Tremlett and her colleagues have a nice diagram there, talk about the risk factor, genetics and environment, and then going into the RIS. And the prodromal phase is somewhat between the RIS and the CIS and MS. It's those signs, early signs, because when you see a lesion on RIS and no specific symptoms of the disease, eventually you have some atypical signs or symptoms which build that prodromal phase and then developing into CIS and MS, which is the onset of the illness. So a few clinical signs and symptoms that can tell us and cinch the diagnosis of MS, and they include numbness, paresthesias, weakness, loss of balance, visual blurring, diplopia, double vision, vertigo, ataxia, unilateral optic neuritis, partial transverse myelitis, bilateral INO, multiple symptoms and signs that are related to central nervous system disease and the inflammation, demyelinations, and neurodegeneration. So always think about those signs and symptoms and know to understand their location. And thinking about the CNS, as you can see, this is taken from Miller. It's a pretty old articles, but he did really a nice job putting a picture of the central nervous system and assigning those areas that are responsible for them. So just look at that. For example, tremor and ataxia related to the cerebellum, and bladder dysfunction to the spinal cord, and others. So what are signs or symptoms that perhaps are not really leading to a diagnosis of MS? We usually don't see a fourth cranial nerve palsy or third. We see INO that I mentioned, which are the fascicular pathways, really thinking connection between 2 or 3 cranial nerves. So, but you don't see isolated fourth or isolated third CN palsy. You don't see very commonly hearing loss in MS. You see it in Susak syndrome, which is also an inflammatory disease, different in MS, but you don't see it often. Homonymous heminopsia, loss of visual field, as we see in strokes. We don't really see in MS. Aphasia, we don't see in MS. We see dysarthrias or ataxic speech, but we don't see complete loss of speech. Seizures Seizure can be seen. Today we see a bit more. It's dependent on the location of lesions, a number and volume of lesion, but it's not a common presentation of seizures and of MS, not a common presentation. Definitely you don't see loss of consciousness. You see some cognitive deficits when we talk about, such as decrease in multitasking, less processing of information, memory loss, short-term memory loss. So word finding difficulty, but not depressed loss of consciousness. Focal cortical deficits, you don't also see progressive motor deficits as well. And also you don't see those extrapyramidal features like tremors and bradykinesia that you see in Parkinson's, and you don't see areflexia, you see hyperreflexia because it's involved in the central nervous system, which is an upper motor neuron disease and not a lower motor neuron disease. This is taken from the National MS Society. I wanted to give a shout out to the NMSS, so I put it in. But important to think that MS is not a contagious disease. There was an article, I remember back in like 2000 or 2001, I think, when I started working in the Corinne Goldsmith Dickinson Center for MS, that was something about sexual transmission of the disease, and that did not pan out. And we all make comments about this article because you don't see couples with MS unless they had MS before they got married. And you see that in a few occasions. But MS is not contagious, is not really directly inherited. We know it's combination of genes and environmental factors, but it's not a direct inheritable genes that we can point to or that we can think, although we don't have the data. It seems that MS is such a complicated disease that's not attributed to one gene. Not always severely disabled. I can tell you I had patients for the last 20 years that are doing very well. You can do well. There is a spectrum in MS, to say honestly, but most of the time you see patient function in very nicely, but you do have those patients that have secondary progressive MS or primary progressive MS that have progressed throughout the years. It's not often fatal. I talked earlier about mortality rate, but definitely not much less than the general population. I mentioned it's 7 to 14. So if we talk on an average of 10 years, yes, there is some reduction, and it's dependent on the MS pattern, on the progression of disease over time, on any high risk for infection and many other complications. However, it's not fatal like many other diseases. Being diagnosed with MS is not a reason to stop working, definitely not. Stop doing things that you enjoy doing and not having children. I know that in the past, people told patients that they cannot become pregnant. As we know, it's mainly of women disease. Female ratio to male is 3 to 1 or even 4 to 1. But definitely many of our patients have become pregnant and had children and enjoyed life. Red flags for misdiagnosing MS, again, I mentioned it continued to be high at 20%. If someone has a normal MRI, it should raise the red flags. You should follow more carefully these patients. Normal neurological examination, also very odd. You want to relook at that. Usually people have some positive finding on exam. Again, many patients do well, so their neurological exam can be normal, but then you'll have some features on MRI that can point to the disease, or some symptoms that happen, but you do not see any evidence on your exam. Atypical clinical features, disease onset at extreme of age, although we do know that MS can occur in childhood, and there is pediatric MS and older age. It's just the disease onset by itself is not usually dominant in those extremes of age. Extraneural systemic disease, any other patterns and symptoms to show that there is other involvement. Usually MS is pretty neurological symptoms, signs and symptoms, and no others, or any vagal signs or symptoms. So pay attention, monitor this patient, always ask for a second opinion. If you need to send patient and refer them to expert in MS, which really, really is important. These are the, so again, MS is a clinical diagnosis. You want to look at the symptoms that patient presents. Sometimes patient would come to see me, and just by listening to them, I would feel this is not MS. I could say this is not MS. I'm not sure what it is at that point, but I can immediately say that the story and all the details together do not point to MS. So that's the part one, and that's the most important thing, is to look at the clinical presentation and the clinical story, as I mentioned earlier, and the neuro exam. However, the MRI are one of the gold markers, biomarkers of disease that help us often to put the puzzle together. It helps to cinch the diagnosis, but you do not rely only on the MRI, you rely on the clinical presentation. So the McDonald criteria have gone few revision. The last one was done in 2017. I'm sure it's not the last, it's not going to be the last one as we get more knowledge. So you can see that these McDonald criteria, the last revision, make it perhaps easier for us to diagnose patients. The criteria have changed that we can diagnose early in MS, diagnose early the disease. Because it's important to diagnose early and treat early, because then we aim to control the disease and to provide higher quality of life. And that's really critical point here. You don't want to misdiagnose, but you want to early diagnose when it's actually the right diagnosis. And always monitor patients. I mean, even if you make the diagnosis. But again, I must say, it's very hard to de-diagnose people. You always want to make sure that you're right with the diagnosis. So anyhow, you can look at the table, and I'm going to point the main changes that happened in 2017, and here they are. Brainstem and cord lesion now are counted among the two lesions disseminated in space and time. In the past, they weren't. So now they're counted. CSF oligoclonal bands, so if we have bands in the CSF as compared to the serum, now be used to substitute for demonstration of dissemination in time in some setting. It's depend when the CSF fluids was done, and thinking about the timing, and if you have other MRI to show new lesion and others. Both asymptomatic and symptomatic MRI lesion can be considered to determine the dissemination in space. In the past, we said, well, we can't count the symptomatic MRI lesion because we already count in the clinical episode, so it's not really fair. Almost you duplicate here. So, but now it's definitely allowed, although optic nerve lesions are still excluded. So we only include the relapse itself, the clinical episode of optic neuritis, a loss of vision, usually partial loss of visions in MS as compared to NMOSD, which you have remarkable loss of vision, but you can have a more than mild loss of vision in MS as well. And lastly, cortical lesions have been added to juxtacortical lesions as determinant for dissemination in space. So we have a few to really help us with dissemination in time and dissemination in space to make the diagnosis of multiple sclerosis. Briefly about the workup, the neurological symptoms, the neurological exam, as I mentioned earlier, is critical. You do want to look at mental status, cranial nerves, reflexes, motor function, sensory function, and gait. And we use few parameters to measure gait, imaging and lab work for MS, which again, I will discuss it in a future talk more in detail. We do general blood tests as we do all the time, CBC, chemistry. You want to check for Lyme, but that's create always a contradictory follow-up, but you need to check it in some instances. ANA, RPR, and ESR, very along fatty acid, VLFA, copper, vitamin B, TSH, HIV, to rule out other, and then the brain MRI, CMT, CSF fluids, and visual evoked potential, OCT, optic coherence tomography, sometimes Chexter X-ray to rule out if it's neuropsychoid. You want to do a thorough lab work initially and check everything, although sometimes you check too much, and then you think, what do you do with the results, correct? But you want to make sure, depend on the symptomatology and the clinical presentation, you do the workup. You don't want to do everything under the world, but there are certain things that you want to include every time. This is, again, just briefly mentioning the magnetic resonance imaging points. This is courtesy of Kathy Costello, a colleague of ours who is a nurse practitioner and have long history in MS. So you can see gadolinium enhancing lesion, either full ring or either partial ring. This is very, very hallmark of MS when you see these gadolinium enhancing lesion. You can see T2 lesions around here, hyperintense, infraterritorial, that means inside brainstem, cerebellum, and you can see a few lesions here, juxtacortical, so really touching the cortex, but above. And then we now talk about cortical lesion, and sometimes we miss them on MRI, and periventricular, around the ventricular, and in the spinal cord. So there are typical areas that patients will develop MS lesions. They are usually oval. You can see they're rounds, and in certain locations. And definitely the enhancement is something that's definitely remarkable for MS. CSF fluids is also important, usually being done in the diagnostic process of patients that come in for an initial evaluation. Bands present in the CSF as compared to the blood can show positive bands, and that can show inflammations, not specific only for MS, but it helps to support the diagnosis of MS. Although if you have negative bands in the spinal fluids, it does not mean that you do not have MS. This is few recent facts about related to the CSF, which make it an important substance and helpful marker in diagnosis of MS. So you can see presence of it's a predictor of CIS to RLMS and RIS to CIS. So if you have positive bands in the CSF, what it means, it can be a predictor to the transformation or conversion from CIS to RLMS and from RIS to CIS. Patients with CIS who had 8 to 12 oligoclonal bands had a 2.5-fold greater risk of conversion to clinically definite MS. We don't really call it anymore clinical definites, but that was in the articles, but means to a full diagnosis of MS than patient with fewer LOCB. So there is some meaningfulness to the number of bands that we that we find in the CSF when you have an LP, and also the presence itself showed inflammation in the central nervous system. What are the phenotype of MS? So I mentioned RIS in relation to oligoclonal bands, but the diagnosis of RIS, it's a coincidental diagnosis. If someone comes to see you or come to see one of your colleagues in the neurology department and have headaches, and then suddenly you see they see something that looks like MS and maybe smell like MS and feel like MS, but it's not, it's just one lesion. You can see RIS. Okuda did many studies related to RIS, and all the data is attributed to his research studies. So, and you can see that often we see one typical lesion, but without any clinical history, you have to monitor and follow up patients. He did a study of a 2-year period that shows that 1/3 of patients with RIS develop a neurological event and were diagnosed with MS. So they went on to develop MS. 1/3 developed a new finding on MRI without any symptoms, so still did not consider MS, and 1/3 show no change. So you can see you have some likelihood, 33% to change and become MS when you start as an RIS. This is actually a photo of patients of mine with an RIS. CIS, it's the first episode of MS, and we usually identify today as already MS because if it's most likely, you have to put all the pieces together again and not misdiagnose patients, but you want to make sure that you follow this patient, and we now treat patients after a CIS. So it's the first episode, which is important to discuss. And the 2017 McDonald criteria actually make it possible to diagnose MS in person with CIS much even earlier with the help and the support of the brain MRI findings. RMS, it's one of the most common MS forms, phenotypes that we see. People should have relapse and then they recover, and then they may have another relapse. But it's an attack, and they can have relapses and remission. Although often once you have a relapse, you do not come to your own baseline. So you can see here that you don't come all the way down to baseline, to the line, you stay up. That means you accumulate some visibility after each relapse. And Dr. Lovin showed in his study, in a wonderful study, that the EDSS do not come back to normal. Although patient may tell you that they feel that they recover fully, the EDSS, the expanded disability status scale, did not come back to the pre-relapse number. So that's done. We do diagnose now relapse and remitting as active and not active, and I have the diagram in the end to talk about that. SPMS, so certain percentage of patients that started with relapse and remitting MS will at some point convert to secondary progressive MS, which you either become active with relapse, continue to have relapses, but ongoing progression of disease, and or without relapses. No evidence of disability accumulation over time. That's really what it means, because you can may have with or without, or relapses, or without progression. So it will be more of the not active SPMS. Primary progressive MS have no relapses. It's from the onset for the disease. You have worsening of neurological function over time, and you have some symptoms without relapses or remission. So, and here as well, you have active and not active. So please review that. And this is what I meant, the revised clinical phenotypes. We still go by the relapse and remitting MS and a secondary progressive MS and primary progressive MS. The progressive relapsing disease was eliminated. We're not really including that under the phenotype of MS. But then each one of them, the relapse and remitting MS, the secondary progressive MS, and the PPMS, primary progressive MS, will identify as being active or not active. And nowadays, also the medication included under the PI, under the package insert, and the indication that's approved by the FDA, which we'll talk more in the next talk. Prognosis of MS. What is there are certain parameter and marker that we use for prognosis and in discussion with our patients. We always try to be hopeful, but I think it's important to think about the markers that may determine more of a unfavorable prognosis of disease, although it's helpful to think about them because these demographic or any other markers can help us be more aggressive with treatment. So demographic and environmental factors that can be more of a poor prognosis is older age, male sex, not of European descent, low vitamin D levels, smoking, and comorbid conditions, any other diseases, autoimmune disease, and others. Clinical factors that also can be associated with poor prognosis in MS, primary progressive disease, high relapse rate, a shorter interval between the first and second relapses, involvement of brainstem, cerebellar disease, or spinal cord onset, poor recovery from the first relapse, a high EDSS score at diagnosis, polysymptomatic onset, and early cognitive deficits. MRI related marker and other biomarker that are associated with poor prognosis in MS are the MRI. Let's talk about them first. A high number of T2 lesion, burden of disease, volume and number, presence of enhancing lesion, gadolinium enhancing lesion, presence of infratentorial lesions, that is brainstem and cerebellum, the presence of spinal cord lesion, whole brain atrophy, and gray matter atrophy. So higher atrophy is associated with poor prognosis. By other biomarker, high number of T2 lesion, which I already discussed, sorry about that, the presence of IgG and IgM oligoclonal bands, so any presence, and we discussed it earlier, the higher oligoclonal bands also make a difference in the prognosis of MS and conversion of MS to definite MS. High level of neurofilament, light chain in the CSF and serum, high level of chitinase in the CSF also were associated with poor prognosis. A retinal nerve fiber layer thinning detected with OCT, optical coherent tomography, also is associated. So all these markers are very, very helpful to discuss the importance of taking treatment in MS and how we monitor patients. The more poor prognostic factors, indicators the patient have, we need to perhaps see them sooner and be more aggressive with medications. I will finalize with the case studies in MS. Again, this MRI pictures is from one of my patients. So talking about a 20-year-old, a young male, African-American male, who had a new onset of sensory loss in both hands. His medical history was optic neuritis 1 year ago, which he recovered well. Current medication, vitamin D, partially adherent to the medications, and cultural consideration to think about the presentation and prognosis in African-American males, which I talked earlier. And brain MRI was done 1 year ago, which you can see it on the left here and shows some disease in the brainstem, so infratentorial disease. These are other cuts of the same disease. So the main question here to think about, does this person meet the diagnosis and having some disease in the spinal cords and lesion on different cuts, and has 2 clinical lesion episodes. Thinking about, I'm going to go back, here you go. So I had optic neuritis 1 year ago, and you see this patient, of course, you want to think about the diagnosis and thinking about the McDonald criteria, but definitely here having 2 episodes in, one was the optic neuritis a year ago and sensory loss now, and has a lesion in the higher cervical, I think it's the high cervical, I'll go back to it in a second. But all this, you want to think, and in African-American male, you want to think about diagnosis and how you aggressively treat. So yeah, IROPS. Thank you. Yeah. So important to think about all and get the picture, get the clinical story, get the neurological exam, and think about all these factors in how you make the diagnosis of MS. Some key points, some pearls. Key to neurological MS diagnosis begins with a good history and a thorough physical exam, neurological exam. Patient functions, ADLs, activity of daily living assessment is critical. You need to see what your patient are able to do. Any deviation from baseline, you need to monitor and evaluate over time, either seeing patients every 3 months, 6 months, or more often. And quality of life assessment is the focus of chronic neurological disease management, important to do. So in summary, MS is a complex disease, is an autoimmune disease. high-risk RIS and prodrome may become a part of the MS spectrum in the next version of the McDonald criteria. So as I mentioned, we'll continue to revise it again and again. Many now patients that were previously will identify as CIS, now with the new McDonald criteria can probably get the diagnosis of MS. And important to diagnose early, as I mentioned, and treat early. We all in agreement with that. Again, you want to minimize misdiagnosis. Ongoing assessment of the presence of poor prognostic indicators, symptoms, treating relapses, starting DMT, disease-modifying therapies or agents, and managing comorbidities, highly important and critical in multiple sclerosis. Thank you so much, and I will be available to questions once it's presented. Thank you again.